You know, centuries ago, map makers would often just draw sea monsters or like massive whirlpools on the edges of maps where they didn't know what was actually out there.
Yeah, they literally just write, "Here be dragons."
Exactly. Here be dragons. And for a really long time, treating clinical cancer was a bit like navigating by one of those ancient maps.
Oh, absolutely. I mean, you knew there was a lethal threat, and you knew roughly where it was located in the patient's body.
Right. But the exact microscopic borders, the internal terrain of the tumor.
It was largely a guessing game.
Yeah, which meant you risked either, missing the disease entirely or causing catastrophic damage to the healthy tissue right next to it.
Which is obviously the last thing you want to do.
Right. But today, according to our source material for this deep dive, which is the highly authoritative medical textbook, Imaging for Clinical Oncology, second edition, we aren't just mapping the borders of the drive-in anymore.
No, we are actually tracking its cellular metabolism in real time.
It's incredible. So if you are a medical student prepping for boards, or maybe a young professional stepping into the oncology clinic, or honestly just a deeply curious self-taught learner trying to master the clinical realities of modern medicine, you are in the right place.
Yeah, we're going to give you the fundamental mechanics of how modern medicine visualizes, targets, and tracks cancer.
Because it's not just taking pictures anymore.
Not at all. The transition from static pictures to functional data is really the core theme of this text. So our objective here is to provide a comprehensive, high-yield exploration of that shift.
We want to look closely at how anatomical and functional imaging protocols actively guide curative radiotherapy and, ultimately dictate patient survival outcomes.
Right. And to understand how we treat the disease, we first really have to understand the physics of how we find it.
Exactly. So the textbook starts by tracing the evolution of imaging, going all the way back to Röntgen's discovery of X-rays in 1895.
Which took a surprisingly long time to evolve. I mean, we didn't get the first computed tomography or CT scanner until 1971.
Right, but today, CT is like the absolute workhorse of the oncology department.
It is. But the text mentions that the software running these machines has undergone a massive shift recently.
Yeah, to save patients from excessive radiation exposure, right?
Exactly. We are moving away from older, what's called filtered back projection, to something called iterative reconstruction.
Okay, so break that down for us. How does a computer algorithm actually turn a much lower dose of X-rays into a sharper clinical image?
Well, it really comes down to computational brute force.
The brute force.
Yeah. So the older method, that filtered back projection, essentially took a single mathematical guess to reconstruct the cross-sectional image of the patient based on how much X-ray radiation passed through their body.
Okay, just one guess.
Right. And if you lowered the radiation dose to protect the patient, the data became really messy, and that single guess resulted in an image filled with visual static.
Like noise on an old TV.
Exactly, lots of noise. Iterative reconstruction tackles this by making an initial assumption about what the patient's internal anatomy looks like. It then simulates what the X-ray data should look like based on that assumption.
Oh, I see.
Then, the computer compares its simulation to the actual messy data collected by the scanner, calculates the difference, and updates its assumption.
And it just keeps doing that.
Over and over, it repeats this cycle, these iterations, dozens or hundreds of times in a matter of seconds.
Whoa.
By constantly refining the mathematical model against the raw data, the algorithm actively strips away the noise. So you get a razor-sharp image of tissue density while exposing the patient to a fraction of the ionizing radiation.
That is amazing. So we get a highly detailed map of the patient's internal density, but CT struggles to differentiate between subtle variations in soft tissue, right?
Yeah, it does. I mean, a tumor might have the exact same physical density as the healthy muscle resting right next to it.
So how do we distinguish the two?
That's where we rely on magnetic resonance imaging, or MRI.
Right, because it doesn't use X-rays.
Exactly. Instead of X-ray attenuation, MRI uses powerful magnetic fields and radiofrequency pulses to interact with the hydrogen protons in the water molecules inside the patient's body.
The textbook places a really heavy emphasis on advanced MRI techniques here, specifically echoplanar imaging, or EPI.
Yeah, EPI is crucial. It relies on incredibly fast magnetic gradient switching, which allows the scanner to acquire an entire 2D image slice in a fraction of a second.
And that speed is what lets us measure something critical, right? Water diffusion.
Yes.
Okay, I want to make sure I'm grasping the physical mechanics here, because the textbook breaks this down into isotropic versus anisotropic diffusion.
Mm-hmm.
So if water is trapped and forced to move in only one direction, Does that tell us we are looking at densely packed cancer cells?
It tells us we're looking at a highly restricted cellular architecture.
Yeah.
Think about it like this. In a pool of liquid or loose healthy tissue, water molecules move randomly and freely in all directions.
Right.
That is isotropic diffusion. But tumors are characterized by rapid, uncontrolled cellular division.
They're crowded.
Extremely crowded. The cancer cells pack tightly together, creating physical barriers. When the MRI scanner measures the movement of water molecules in that area, it detects that the water is physically restricted from moving freely.
Which is anisotropic diffusion.
Exactly. And by mathematically quantifying that restriction, we are essentially mapping the microscopic cellular density of the tissue without ever using a scalpel.
That's wild. But even with the density data from the CT and the soft tissue architecture from the MRI, we are still just looking at anatomy, right?
Okay.
Like we're looking at the structure of the buildings and the roads on a city map. But a tumor is a living, aggressively hungry entity. So how do we see what the tumor is actually doing?
For that, we use positron emission tomography, or PET.
Okay, so this is the leap from anatomical imaging to molecular imaging.
Exactly. In oncology, the most frequently used radiopharmaceutical for PT is 18F-FDG.
And that's essentially just sugar, right?
It is. It's a molecule of glucose that has been chemically tagged with a radioactive fluorine-18 isotope.
Okay, and because cancer cells are rapidly dividing, they have incredibly high metabolic rates.
They do. They're starving for energy.
So they consume the radioactive sugar much faster than the surrounding healthy tissue.
They absolutely hoard it. And as that fluorine-18 isotope decays inside the cancer cell, it emits a positron.
Right.
That positron travels a microscopic distance before colliding with an electron in the tissue. This collision causes an annihilation event.
Which sounds intense.
It's just basic physics, but it emits two gamma rays in exactly opposite directions.
Oh, okay.
The PET scanner is essentially a ring of highly sensitive detectors that catch those simultaneous gamma rays. The computer then traces the trajectory of the rays backward to find the exact point of origin.
So if CT and MRI give us the highly detailed street map of a city, a P-scan is like looking at a satellite heat map of that same city at night.
That's a great way to think about it.
Like, the P-scan doesn't show you the shape of the buildings or the layout of the roads, but it shows you exactly where the lights are turned on, where the power grid is being drained, and where the most intense metabolic activity is happening.
And the clinical implications of that heat map are profound.
How so?
Well, an anatomical CT scan might show a lymph node in the patient's neck that measures, say, 5 millimeter.
Which is tiny.
Right. Based purely on size, standard anatomical criteria would label that node as perfectly normal.
Okay.
But when you overlay the PET data on top of the CT, you might discover that this structurally normal node is emitting massive amounts of gamma rays.
Meaning it's metabolically hyperactive.
Exactly, because it's packed with microscopic metastatic cancer cells.
Oh, wow. So if the PE scan shows the tumor glowing so clearly, why don't we just use that functional image to guide the surgeon's scalpel or the radiation beam?
You can't rely on PE for spatial margins.
Why not?
Its spatial resolution is relatively low. The glow is diffuse. The PET scan tells the clinician where the disease is active, but you still absolutely need the structural data from the CT or MRI to define the precise physical boundaries of the tissue.
Right, which brings us to a crucial pivot in the textbook. Because once we map the city and identify the active threats, we have to drop a highly precise therapeutic payload.
We move from diagnostic imaging to radiotherapy planning.
So if we can see the exact physical border of the tumor on an MRI, why don't we just program the radiation machine to shoot exactly inside those visible lines and spare everything else?
Because treating only what you can see guarantees the cancer will return.
Really?
Yes, this is the concept of target delineation. What you see on the scan, the visible mass, is the gross tumor volume, or GTV.
Okay, the GTV.
But cancer is microscopic. It sends out invisible tendrils of disease into the adjacent tissue.
Right, of course.
Furthermore, patients move, and machines have microscopic mechanical tolerances. Therefore, the radiation oncologist must draw a larger boundary called the planning target volume, or PTV.
So the PTV is like a safety margin.
Exactly. This margin accounts for the invisible microscopic spread and the physical setup errors of daily treatment. And this entire volume must be sculpted while painstakingly avoiding the OAR.
The organs at risk.
Right, such as the spinal cord, the optic nerves, or the heart.
Now, if you're listening to this and thinking, wait, didn't we just establish that MRI is vastly superior to CT for defining the soft tissue borders of a tumor? Why do we still need CT for radiation planning?
Yeah, that's a massive dilemma covered in the text.
Right. Why not just use the MRI to draw the PTV?
It really comes down to the fundamental physics of the scanners. MRI suffers from inherent spatial distortion.
Distortion, like the image is warped.
Basically, the magnetic field is perfectly uniform in the dead center of the scanner bore, but as you move outward toward the edges, the magnetic field lines curve slightly.
Oh, interesting.
The computer reconstructing the image assumes a perfect grid, so it places pixels in slightly the wrong physical location.
Does a tiny warp really matter that much, though?
In a diagnostic setting, no. A 2 mm warp in a hip muscle is irrelevant. But in stereotactic radiotherapy, where you are delivering a highly ablative dose of radiation.
A 2 mm spatial distortion means you miss the edge of the tumor and sever the patient's spinal cord.
Precisely.
Wow. So the biological accuracy of the MRI comes with a severe physical risk.
Furthermore, radiation physicists calculate the deposition of the radiation dose based on electron density.
Which is how much the patient's tissue will physically absorb the X-ray beam.
Right. CT scans inherently measure X-ray attenuation, which correlates directly to electron density. MRI uses magnets and radio waves, so it provides zero information about how an X-ray beam will interact with the tissue. You simply cannot calculate a safe, accurate radiation dose using standard MRI data alone.
So the current standard is to scan the patient on both machines and then use specialized software to digitally fuse the images together.
Yes, you overlay the soft tissue brilliance of the MRI onto the rigid physical accuracy of the CT.
Though the text does note that the cutting edge of the field is trying to solve this with MRI Linux, right?
Yeah, those are machines that have an MRI built directly into the radiation delivery system. It's fascinating tech.
But there is another physical variable we have to account for beyond 3D space, which is time. The textbook introduces the 4D CT scan. What is the clinical necessity of adding time as a fourth dimension?
The clinical necessity is that the patient is breathing.
Oh, right.
If you are targeting a tumor in the lung, the liver, or the pancreas, that mass physically moves up and down several centimeters with every single breath.
So if you take a static 3D CT scan,
you're just capturing a snapshot in time. You might image the tumor at the very top of the inhalation cycle. But during the actual 5-minute radiation treatment, the patient continues to breathe.
And the tumor continuously slides completely out of the path of the radiation beam.
Exactly. A 4D CT scanner captures the full cycle of human respiration. It allows the oncologist to watch the tumor move in a loop and create an internal target volume that encompasses the entire physical path of the tumor's motion.
That is just an astonishing level of physical engineering.
It really is.
But, okay, if a PET scan is so incredibly sensitive at finding active cancer, and we have these amazing 4D targeting tools, why don't we just use a PT-CT scan on every single patient every single time we suspect anything abnormal?
Because clinical oncology is a constant exercise in risk-benefit analysis, and nowhere is that more apparent than in pediatric oncology.
Right, because kids aren't just miniature adults.
Exactly. Their tissues are rapidly dividing and growing, which makes their cells far more vulnerable to DNA damage from ionizing radiation.
Which is a huge concern.
Yeah. Huge. Furthermore, because we cure a high percentage of childhood cancers, these patients have 6, 7, or 8 decades of life ahead of them. That is a massive window for secondary radiation-induced malignancies to develop.
So the very CT scans used to stage a 10-year-old's leukemia could theoretically cause a fatal thyroid cancer 30 years later.
Unfortunately, yes. Which is why the governing philosophy in pediatrics is the ILERA principle, as low as reasonably achievable.
ILERA. So the use of CT and PE is heavily restricted for kids.
Highly restricted. The textbook emphasizes that modalities utilizing non-ionizing radiation, specifically MRI and ultrasound, are heavily prioritized for both initial staging and long-term follow-up.
Even though MRI takes way longer.
Right. Clinicians will routinely sedate a toddler to keep them perfectly still for a 45-minute MRI scan rather than doing a 30-second CT scan.
Wow.
Because eliminating that radiation exposure is mathematically worth the logistical hurdle.
That makes total sense. So the imaging protocol is entirely dictated by the biological reality of the patient. Let's look at another highly customized site-specific strategy detailed in the text. Prostate cancer.
Okay, yeah.
Prostate imaging has been revolutionized by something called multiparametric MRI, or MPMRI. Historically, if a patient had prostate cancer, the entire gland was treated uniformly, right?
Yes, that was the standard.
How does MPMRI change the physical delivery of the radiation?
It allows us to pinpoint the DIL,
The DIL.
the dominant intraprostatic lesion. You see, prostate cancer is rarely a single uniform sphere. It is often multifocal, but there is usually one specific area within the gland that is the largest, the most aggressive, and the most densely packed with tumor cells.
Okay, so by utilizing the diffusion-weighted imaging we discussed earlier,
The MPMRI identifies the exact coordinates of this dominant lesion within the prostate.
which allows the clinical team to do what is called a boost.
Exactly. The radiation oncologist designs a plan that delivers a standard curative dose to the entire prostate gland to handle the microscopic disease, but simultaneously delivers a hyper-concentrated, massive dose of radiation directly into the core of the DIL,
So it aggressively sterilizes the most dangerous part of the tumor.
while deliberately keeping the dose lower at the edges of the prostate to protect the adjacent bladder and rectum walls from permanent damage.
The customization is just incredible. Another site-specific protocol the textbook highlights is for lymphoma. And for this disease, 18F-FDG-PTCT is considered the absolute, undisputed gold standard.
Yes, it is.
Why is lymphoma treated so differently than a solid tumor in the prostate?
Because lymphoma is a systemic disease of the lymphatic system. It frequently involves multiple lymph node chains scattered across the neck, chest, abdomen, and pelvis, as well as organs like the spleen.
So relying on anatomical size is incredibly misleading here.
Completely misleading. Lymph nodes naturally enlarge in response to normal reactive inflammation, like, fighting off a common cold.
Right, so an enlarged node doesn't necessarily mean cancer.
Right. The FDG-PET scan bypasses that structural ambiguity and directly highlights the active hypermetabolic lymphoma cells across the entire body in a single sweep.
And the textbook details a very specific metric used by radiologists to grade this PE activity called the Deauville 5-point scale.
The Deauville scale, yes.
How does a radiologist objectively decide if a lymph node is dangerously hypermetabolic or just normally active using that scale?
The genius of the Deauville scale is that it uses the patient's own internal organs as a baseline control group.
Oh, that's clever.
The radiologist measures the glucose uptake in the suspected lymph node and compares it to the natural baseline glucose uptake in two specific areas, the blood pool in the mediastinum, the center of the chest, and the healthy liver tissue.
Because both of those areas have consistent, predictable rates of metabolism.
Exactly. So if the lymph node is consuming more glucose than the surrounding blood pool but less than the liver, it scores a 3. But if the lymph node is burning significantly hotter and consuming far more glucose than the healthy liver, it scores a 4 or 5, indicating active abrasive disease.
So it totally removes the subjective visual guesswork.
It does. It provides an objective biological metric to determine if the chemotherapy is actually working.
Okay, so let's look at that crucial next step. We found the tumor, we targeted it, and we treated it with radiation or chemotherapy. After the treatment is over, we bring the patient back, do a scan, measure the lump, and if it's smaller, we know we won, right?
Well, that assumption is a massive historical blind spot in oncology.
Wait, really?
Yeah. What you're describing is the old-school anatomical approach known as RECIST.
Response evaluation criteria in solid tumors.
Right. RECIST relies on measuring the longest unidimensional diameter of a tumor on a CT scan. If that measurement shrinks by a certain percentage, it's classified as a response.
Makes sense on paper.
But consider the biological effect of modern, highly targeted radiotherapy. The radiation obliterates the cancer cells, but the physical scaffolding of the tumor, the fibrotic scar tissue, often remains in place.
Ah, so the tumor is entirely dead inside, but the outer shell hasn't collapsed yet.
Exactly. So according to RECIST, the treatment failed because the physical diameter didn't shrink.
Which is incredibly misleading for clinical decision-making.
It is. And this limitation led to the development of PERSIST, which uses PET imaging to evaluate the metabolic response.
So PERSIST ignores the physical diameter.
Entirely. Instead, it quantifies the maximum standard uptake value, or SUV peak.
Okay.
A massive tumor might not shrink a single millimeter on a CT scan for 6 months following radiation. But if a follow-up PET scan reveals that the SUV peak has plummeted to the baseline level of the surrounding healthy tissue.
Then PERSIST tells the clinician that the treatment was a complete metabolic success.
Yes, the structural building is still standing, but the power grid has been entirely shut off.
I love that analogy. And we also use follow-up imaging to monitor the collateral damage of the treatments themselves, right?
Oh, absolutely.
Because the textbook notes that cancer patients are at a highly elevated risk for venous thromboembolisms, deep vein blood clots, and pulmonary embolisms.
Which can be fatal.
Right. Furthermore, Modern immunotherapies can cause the patient's own immune system to attack healthy organs, leading to conditions like pneumonitis in the lungs or colitis in the bowel.
And all of which present as distinct visual patterns on a CT scan that the radiologist must catch.
So monitoring the physiological cost of the treatment is just as critical as monitoring the tumor itself.
It's an integral part of survivorship care.
Now, looking to the horizon, the final chapter of the textbook introduces a concept that feels like it basically belongs in a science fiction novel.
You're talking about radiogenomics.
Yes, radiogenomics. Let's use an analogy here for the listener. Imagine looking at a sprawling forest from a satellite. You obviously cannot see the individual pine beetles destroying the trees, right?
Right, they're too small.
But if a computer algorithm measures the exact fractal pattern of the dead brown trees versus the healthy green trees, the algorithm might know exactly which specific species of beetle is responsible based entirely on the pattern of destruction.
That's a really good way to visualize it.
Thanks. But how does the computer algorithm look at an MRI and figure out the invisible genetic mutation driving the tumor?
Well, to the human eye, an MRI slice is just an image made of varying shades of gray. But to an advanced algorithm, that image is a complex mathematical matrix of millions of 3D data points called voxels.
Voxels, okay.
Radiomics is the process of extracting the mathematical texture from these voxels. The algorithm analyzes gray-level co-occurrence matrices.
Say that again?
Gray-level co-occurrence matrices. It's essentially measuring the microscopic contrast and spatial relationship between every single adjacent voxel.
And what does that tell us?
This quantifies the exact heterogeneity of the tumor.
It measures how chaotic the internal structure is.
Precisely. It measures the chaos of the internal angiogenesis, the haphazard blood vessel creation driven by the cancer. Radiogenomics attempts to link those specific mathematical textures to known genetic mutations, like a KRAS or EGFR mutation.
Oh, wow.
If the clinical data proves that a specific chaotic voxel pattern on an MRI always perfectly correlates with a highly aggressive radiation-resistant genetic mutation.
We have just created a non-invasive surrogate for a surgical biopsy.
Exactly.
So we bring this full circle. Imaging in clinical oncology isn't just a diagnostic tool anymore.
Not at all.
It is the bridge between detecting the disease, delivering the highly localized intervention, and reading the genetic code of the threat.
It's totally revolutionized the field.
So to cement these concepts, let's put you, the listener, in the clinic. Here is your review scenario based on today's material.
Okay, let's hear it.
You have a 10-year-old patient who presents with a newly discovered palpable abdominal mass. Based strictly on the physical and biological principles we discussed, what imaging modality should you immediately prioritize for staging the extent of this disease, and most importantly, why?
Well, as a clinician, you must adhere to the Alaroe principle. Because this patient is a child with rapidly dividing tissues and a long expected lifespan, they are highly susceptible to long-term DNA damage.
Right.
Therefore, you must prioritize non-ionizing modalities, MRI and ultrasound, over a CT scan. This drastically reduces the risk of a secondary radiation-induced malignancy developing decades later.
Which perfectly illustrates the calculated reality of modern oncology. So I leave you with this final thought to mull over. We just discussed how radiogenomics and machine learning algorithms are beginning to read the invisible mathematical chaos hidden inside a standard scan. As this technology fully matures, if a computer can eventually read a tumor's exact genetic makeup, its internal blood supply, and its chemical resistance profile just by analyzing the voxels of an MRI, will the traditional invasive surgical biopsy become a relic of the past?
It's a huge question.
And if we can read the genetic code of a tumor without ever touching it with a scalpel, how will that rewrite the daily workflow and the entire required skill set of the clinical oncologist?
It changes everything.
It really does.
Yes.
So keep questioning the tools you use, keep pushing the boundaries of what is medically possible, and never stop analyzing the data. We have come a very long way from drawing sea monsters on the edges of the map, but the internal cartography of the human body still holds plenty of uncharted territory. Until next time.